they're taught for the most part to kind of down code a little bit and code in such a manner that they don't get audited and we don't get, our hand slapped on the back end. You can have people that aren't as incentivized as you down coding your office visit.
We had a whole year of training just on coding. No, I'm just kidding. We didn't have anything.
Welcome everyone. My name is Zach Ruhl. I'm the CEO at Maia. Today we are discussing one of the most important and often misunderstood areas in healthcare, E&M coding. When it comes to E&M coding, even small inconsistencies in documentation or code selection can have a major impact on a practice's reimbursement, revenue, physician workflow, compliance, and their overall operational efficiency. Today, I'm joined by Dr. Nicholas Strasser and Dr. Salman Chaudri, who both bring a wealth of knowledge and a deep expertise, not only in their orthopedic practices, but also in coding as well. Today, we're going to talk about real-world challenges that they're facing today, how those challenges have changed over the years, and how AI and automation may fundamentally change how their practices do their E&M coding. Thank you both for joining.
Thank you.
Thank you.
Dr. Chaudri, I'm going to start with you. Can you tell me a little bit about how coding worked as you came out of your residency and how you've seen it change over the years?
Yeah, so, when in residency, no one really gives you a script on how and what to do. As you come out and, you have different avenues of joining a private practice, a hospital group, multi-specialty group, depending on who you join and, who your mentors are. They just kind of throw you in on the first day and you're seeing patients in the clinic and, the seeing the patients and diagnosing them is the easy part. It's getting the proper verification and proper reimbursement for what you're doing becomes the difficult part as you kind of grow your practice. Initially, when I started, it was kind of trial and error, just seeing what my partners did and but you miss out on a lot of the little details in those beginning stages. And at this point, over 17 years, I've learned a lot that's, I didn't know when I started.
Yeah, I remember you telling me that coding even changed. You noticed performance and behavior changes when you switched practices, right? Can you talk to me a little bit about that?
Yeah, so, I was in a small three-man group when I first started, and obviously it was kind of eat what you kill, and, like if you didn't get reimbursed, you didn't get paid. Now we're in a multi-specialty group. We have hundreds of coders for, multiple doctors, and everyone's checking everything. But initially, just for an example, if you were to see a patient and review an MRI and set them up for surgery, but you don't know what you're doing, you're coding, either new or established level 2 or 3, and not getting the proper reimbursement, which you should be coding a established level 4 if you're interpreting MRIs and X-rays and setting people up for surgery.
Yep, absolutely. Dr. Strasser, can you tell us a little bit about your experience as you came out of residency?
Yeah, we had a whole year of training just on coding. No, I'm just kidding. We didn't have anything. It was basically just kind of thrown to the wolves. I think the most coding I had was when I had to, complete the clinic coding for one of our attendings at the end of the day, and I had no idea what I was doing. Or what we were doing it for. And so when you get into practice, you get a little bit of that in fellowship, a little bit of discussion, depending on where kind of fellowship you're part of. I was more academic residency, so that wasn't as big a focus, but fellowship was private. And so we definitely talked about those things. And we had mentors who kind of took us through CPT coding for surgery and E&M coding for clinic and kind of how they approached it. And you saw different ways and different trends. But at the end of the day, you get out into practice, and you really have, it's a completely different language to some degree. And even when you're talking about a procedure in clinic or you're dictating the operative note, I've learned that I have to learn how to speak in that language so that I can capture what I'm actually doing. It's different than what you were kind of taught as part of the technicalities of your surgery. Partial excision of bone, for example, or terms like saucerization. I don't even know, like I never heard that until I was 1 or 2 years into practice. And so those are some of the challenges that I ran into, especially early on in practice.
Interesting. And maybe you were performing saucerization and not getting paid for it.
I didn't even know it. Didn't even know it.
Something else.
Just to add on that too, to kind of follow up Dr. Strasser's point. I think as surgeons we come out and we are very focused on surgery, and we're kind of in tune with what we're billing for surgery. If we do a plateau fracture, we're billing for that, plus the meniscal repair. We're taking off an X-fix, we're billing for all that. In the clinic, it's different. But, as a healthy orthopedic practice, you're probably seeing 80 to 100 patients in the clinic per week and only probably performing 10 to 15 surgeries, right? So even though the money's in the surgery, there's still 80 to 100 patients that you're seeing that you need to bill for correctly to kind of get your reimbursement.
Yeah. And that moves the needle too. I mean, that definitely moves the needle on the reimbursement. Clinic is a big deal in terms of what you do and see. And if you're doing things like injections or procedures, making sure that you accurately document that so that you can get the appropriate coding. And I've noticed my own practice is more than just generating for surgery. Obviously there's that part. It's kind of the part that keeps your surgeries booked, but it is also the part about seeing other patients, doing injections, getting referrals, like all those things are so incredibly important. And I think we overlook that a little bit.
Absolutely. The surgeries are kind of what catches your eyes at first, right? But then, over time, you notice that there's a lot of teeth in your E&M clinic coding as well. And at the same time, if there's issues in your E&M and clinic coding, that's causing a lot of friction between you and your coders and billers, your administrative team, because that's 75 up to maybe 90% of your encounters with a patient happen in the clinic.
Yep.
Dr. Chaudri, can you tell me a little bit about how you've seen that friction and how the incentives between physicians and coders kind of make this process a struggle?
Yeah, I mean, obviously, as surgeons, we make a very good living, but it's all based on the coding. And the people that come in and code for us, especially in my organization, we have, several hundred people coding for several different physicians, not just orthopedics, but they're probably, maybe a low-level college degree with a course in coding. So they come out and they're, again, making a decent living, but they're not making what we're making. For them, it's a job. So they will, they're taught, for the most part, to kind of downcode a little bit and code in such a manner that they don't get audited and we don't get, our hand slapped on the back end. So they're trying to do the least code where we need to maximize what our efforts are in the office. And if we're sitting there talking to the patient for 20 to 25 minutes on a surgical procedure and the complications, like we need to be able to be reimbursed for that. So there is the struggle with that. Again, if a new surgeon comes out and does not know the rules of CMS and what the changes happen, and I would take this year example, as of January 1, there's new rules on E&M coding. So if you don't understand what's going on and how that is changing, you can have people that aren't as incentivized as you downcoding your office visits, and you're losing out on a lot of revenue, which is not just for the physicians, but it helps provide for our overhead. So the the MAs and the nurses in the office that we, take care of, the PAs that help us, keeping the lights on, that's all part and parcel with our reimbursements.
Dr. Strasser, how have you seen that issue of incentives and kind of procedural friction manifest itself at your practice?
I tend to agree with what Sal said that, they tend to the down coding definitely does occur. You need to, it comes down to making sure you're doing the appropriate documentation, that if you have that long discussion, that gets documented in the chart, because that's kind of what they're going off of. And so I think that's where I've learned so much in terms of making sure, like, what are the key points that I need to make sure that I document, that I put that into the record so that I can appropriately get the credit that we get for it. And that's part of where I think AI is helping too, a lot of this stuff to point out. It also is like immediate feedback for me, that the idea that, hey, you need to make sure you mention this, this, and this if you did it, because then you can put it into the record right away, because that's where the ultimate scorekeeper takes place, is the medical record.
I love the transition. Let's start talking about how technology can improve the E&M coding at your practices. Dr. Chaudri, curious your thoughts about what Dr. Strasser just said about how smart recommendations and automation could kind of transform how this works.
Yeah, I think Dr. Strasser is right on the point. I mean, I think having a good coder is a phenomenal thing to have, and you can have a good back and forth with them, but it's still a human interaction that takes time, right? So I go and see the patient, I bill, they look at it in a day or two, and then they get back to me. So it may take a week for them to get back to me and say, hey, you did not document this, we need to add this, or we can't bill this. Whereas with Maia and the AI programs, you'll get instant feedback, when it's integrated into the system that you're on. And it will tell you, hey, you hit these bullet points, so you can bill to this, or it kind of reaffirms what you're billing to, or you did not hit this bullet point and we cannot do that. So I think the instant feedback of seconds versus days is very unique to AI, and I think that's where the future is.
I agree with that. I think tools can come in and be a force multiplier for what you're already doing by ensuring your documentation meets with the CMS and payer guidelines, and that the codes that are being selected are kind of reinforced by that documentation. And one thing we haven't touched on is that your ICD-10 code needs to line up with the E&M level that you're selecting, or payers maybe automatically denying those or automatically downcoding them on their end as well, which is a webinar for another day that we'll be launching soon.
One thing I would add too, and this is just on my end, post-ops, right? You can't charge for 90 days. So when I see a patient post-op and they're close to that 90 days, I have to go into the chart and actually look at the date of surgery and kind of count it out on the calendar. Whereas with the integrated AI, that kind of pops up automatically. I mean, it's a very, very small detail, but I think that helps significantly.
That's one of those things that drives me nuts, that it doesn't happen automatically. I mean, it's you're on a computer, it knows it's there for a post-op. Just do the work, and that's where I think AI will be so helpful.
Absolutely. And then you both can get back to your patients and spend time with them face to face rather than face to face with your computer. Okay. Thank you, Dr. Chaudri, Dr. Strasser. Really appreciate you joining this webinar, sharing your expert opinions. I will not take up any more of your time. We do have more webinars coming. We have a webinar on surgical coding. We have a webinar on denial appeals, a webinar on down coding, and more coming soon. Thank you, audience, for tuning in to this webinar. Have a great night.